Welcome, folks, back to Free My Pain Now with Dr. Matt DiDuro. Today I have a special guest, Dr. John B. Mullins. You've been in healthcare 45 years?
Very long time, yes.
You look young. I mean, I'm not going to...
I graduated from Emory Medical School in 1966. And then it's a long program to get there and had to pay back for medical school in the Air Force, active duty. And then
You're a flight surgeon?
I was.
For the Navy?
For the Air Force.
Air Force, that's right.
And then eventually, actually only about 6 years ago, retired from the Air National Guard, where I was the chief medical officer for the state of Georgia.
How long did you do reserves? 30 years?
Just 27, I think.
Yeah, that's great. Thank you for your service. And so you went on and you specialized in plastic surgery.
Yes.
And you've been in Atlanta for close to 34. You started your practice in 1985.
85, yes.
And been a plastic surgeon 34 years here in Atlanta. You're well known. People, your name pops up a lot.
I hope so.
Yeah, you've done some great work, and your reputation precedes you. And I love the fact that we have a patient in common. I sent you those pictures of her. How cool her legs have changed over the last 6 months, Miss Carol.
Yes.
But really what got me excited to bring Dr. Mullins on is about a year and a half ago, through our friend, John Whaley.
Yes.
Yeah, John, who, shout out to John out there, who was an early investor in TRT.
Right.
And he was the one that said, hey, I think that this device will help your diabetic neuropathy patients. So that's how I got involved with TRT. But with you, as a plastic surgeon, we also, you do a lot of wound care. I was surprised when I visited your clinic how...
I do a great deal of wound care. And John Whaley was one of my pilots when I was a flight surgeon. And so I've known him for many, many years. And we go way back, and we trust each other. And when he brought his story about this treatment with Acoustic Wave, I listened to it with a lot of interest. Since he's not one to just make things up, and indeed used it in a very difficult case.
Do you remember your first case you used it on?
First case was an extremely difficult case of a man who everyone had
given up hope.
Said he must have the leg amputated.
If I remember correctly, he was a diabetic neuropathy patient.
Diabetic end-stage renal disease, and he'd walked around with a piece of glass in the bottom of his foot.
How long was that glass in the bottom?
Almost 2 weeks.
2 weeks before he knew it. So that's, one of the things with diabetic neuropathy, because of lack of blood flow, those sensory nerves kind of weaken and go into this dormant state. And so he couldn't even feel it.
Well, it's called protective sensation.
That's right.
And he
lost his protective sensation.
Lost his protective sensation. And that's one of the downsides to any kind of neuropathy, but the diabetic neuropathy particularly in the palms of the feet are
And I got to work with you on that case.
Yes.
And, unbelievable changes. They basically had said he's going to have an amputation. We thought below the knee.
And quite frankly, I shared that same that same sentiment until he started demonstrating a tissue regeneration that I could not explain.
Right. And we have pictures of this, and they're too graphic to show on our channel. But, literally every week we would take pictures. We would meet at your office. We would treat this gentleman, and we couldn't believe the changes. Some of the pictures we sent to Dr. Thomas Liu out in University of California, San Francisco, he was like, these are the stem cells. It never really scarred over. Right? That never scarred.
No, it regrew.
It regrew. The tissue regenerated, and
not only that, but I actually amputated one of the toes in the office. The distal phalanx, and it was clearly non-viable. And over the course of the next 5 to 6 weeks, that digit actually increased in length.
it looked like it was starting to grow back, which was wild.
It was like a starfish. Or a
We
salamander.
just didn't think we have that in our. It's not in any medical books.
No, and radiographically, you could see evidence of bone.
And just to
growing.
remind our listeners, we had John Warlick on, who's CEO of TRT, and in Austria, they've been using this for the last 10 years, and they have more documented cases for non-healing fractures in the lower extremities. They're not healing because there's a poor blood supply. So what the beautiful thing about this acoustic wave, and it's an unfocused, low-intensity, extracorporeal shockwave therapy, is that it helps decrease inflammation, improve blood supply by sometimes 300%, they say in the articles, but it also activates those resident stem cells to come out of this dormant state, and then calls for all these other helper cells. The young man that was on before you, Richard, who had a stroke, you and I have talked before because you've seen some of the stroke
Yes.
patients we've worked on, and I said, Doc, how is this happening? What are we doing? I mean, and I don't even think we know why it's happening.
No, I don't think we're totally sure. And you talk about a non-union of a joint, and there are more reasons for a non-union than simply
Blood supply.
blood supply. There's vascularity of the tissue, but there's also
Fascia. Even in that patient.
and if they get infected, you have at least colonization, and that can slow the process down. False motion can slow the process down. That's why most fractures have to be fixed so they can be allowed. But if and we now know that there's some slight motion is probably beneficial. But if it moves too much, that's why we set broken bones.
Mm-hmm.
They have a chance to mend. But there's what the acoustic wave does with its release of the cytokines and the vascular endothelial growth factor and the stem cell factors that clearly something is going on.
Mm-hmm.
And there is science where they're able to look at these growth factors and show an increase. And all we have to do is clinically put it together and have a really good study. But it's difficult to do a good long study. To be statistically significant, it have to be at least 300 patients.
Right.
And you'd have to match up for controls. You'd have some people that would have a sham.
Right.
And I understand that they've got a sham machine out there
Mm-hmm.
that doesn't really deliver the acoustic wave, and you put a curtain so the patient can't see.
They don't know what's being used.
And
right.
so it will make the noise
Mm-hmm.
like the device, but it won't be actually sending the.
I like
energy in.
explaining to patients it's like taking a thunderbolt and lightning and putting it into an applicator.
It is.
Because it's the high pressure, low pressure that I like the fact that it changes that cell membrane permeability and what happens.
It does, and they are fairly certain there's certain bacteria.
Yeah, it's got that
That
antimicrobial effect.
This antimicrobial factor is kind of the big deal. This L37 that they talk about, kind of poorly understood. But one of the interesting things about that patient number one is between treatments, he got nothing.
No therapy in between.
No therapy in between. No wound care.
We didn't even know if his blood glucose levels were good.
We didn't know anything. And he certainly, he didn't have any antibiotics and would come in just with a pair of socks on.
He had necrotizing fasciitis in certain parts. That's why you cut that one digit off.
Well, that was just plain dry gangrene there. But had he had necrotizing fasciitis, then I'd have had to get him to the OR. And
You use some really cool stuff. Can we talk about some of the stuff the pig bladder uses?
Sure.
I mean,
Yeah.
that is pretty groundbreaking stuff as well.
there are several biologics out there that a lot of companies coming up, not only with stem cell, but with other. The pig bladder is just one of them, but there's human
growth
that have human skin that's processed, and of course now we're seeing the stem cells come out that are getting processed, and so we're just on kind of the cutting edge of some of these biologic.
I was in your office and we got to treat an infected snake bite. No, I'm sorry, bug bite, right? Didn't we do a couple bug bites?
It could have been a brown recluse spider, I
Yep.
think.
And then as a breast surgeon, what was the thing you said? One of the number one issues you have after breast implants is contracture.
Sometimes contracture, yes. And I've started treating some of those.
Clinically, what are you seeing? Is it helping? Is it?
Well, it's not as dramatic as some of the others. But one of the most fascinating cases I have, though, is a woman who lost her sensation of the nipple-areola complex after surgery 5 years ago. And I was involved, not with the original, but she had a reason that I had to go and do a revision. And after getting the revision done and having her cosmetically look right, she said, well, can you do anything? I wish we could do something about my loss of sensation. And I said, well, I got this machine here. And I treated her, and she came back like 10 days later with sensation. She said she hadn't felt
One treatment?
One treatment. That she had not felt anything in that breast.
And that's working with the sensor
for 5 years. Not only did she have increased sensation, but her erectile function was working in that nipple.
Wow. So TRT holds a patent for elongation of neural growth or peripheral nerve regeneration, which is pretty cool.
I think that's a valid patent.
That is cool. Not many people can make those claims. The fact that you're seeing patients in your clinic that are getting good improvements. I know we're going to have a couple minutes with you right after this segment breaks, and we're going to talk about some groundbreaking possible research coming down the line. I'm really impressed with the work that you're doing, and this is one of the reasons why we bring in doctors like Dr. Mullins, is because you want to build that team around you of great healthcare practitioners, and this is one of the top guys in Atlanta. So I'm so grateful to have you on and be working with you on this. And could you help me? You explain the research stuff that I don't always get. So.
No, you get it. You get it just fine, Matt.
You're good. So you work with some cardiologists.
I work with some cardiac surgeons. One of my things to do as a plastic and reconstructive surgeon is sometimes get involved with the closure or a difficult wound, particularly when the wound, for some reason, it falls apart or it's infected or there's a mechanical disruption or something, and then the heart is doing fine, but the covering has to be fixed. And so I get involved with getting the bones back together or getting muscle over it and things like that. Also, should there be an infection, I get involved with management of that in different ways. And one of the things that I've been looking at and doing some research on is using the antimicrobial effects of this acoustic wave to treat some of these infections.
So especially, I know I had a patient who had the left ventricular assist device,
yes,
the LVAD.
Yes.
And you said that these people, as they're waiting for a heart transplant, if they don't get the heart transplant, they typically will die because of an infection because there's an outside.
Well, it's a possibility, and one of the things that has to happen is that there's a power source that goes to that emerges from the body, usually in the abdomen. And when you have a foreign body emerging from somewhere, there's always a chance of infection.
It's open wound.
That's why we don't like to leave IVs in people for too long. It's an open wound, and if that should happen, then the usual thing in medicine is you take the foreign body out. Something like this, the LVAD, you can't take it out. And we can move it sometimes. We have to a different site. But I've been impressed. I've got some interesting suggestive data that by treating this with acoustic wave that I can reduce the amount of inflammation and probably reduce the infection. I've had a couple of patients that cleared very promptly after one or two treatments.
Clinical antidotes, and that's big, and possibly a future IRB study down the line.
Yeah, at least a pilot study get going on it, but it's in the works.
That's exciting, and to have someone like you on our team working with this, and the TRT device has been cleared by the FDA to help decrease pain, improve blood flow, and
the big thing is that at this point, and it's been studied very well by the FDA, is it shows that it's not harmful.
It's very safe.
Very safe, and there's very little downside to it. And so with that knowledge, then we feel a lot more comfortable.
We don't use it on pregnant women. We don't use it over any type of cancerous skin lesions or on patients that have had cancer. I do notice that if you've had a cortisone injection, not to use it for about 4 or 5 weeks afterwards. I have found that can either disperse the cortisone, or not all the cortisone is getting into that area. So,
well, I think you've got a problem that locally the cortisone is an anti-inflammatory a drug in itself. One of the interesting things that I've also treated some keloids, and one of the treatments for keloids is injection with Kenalog.
So keloid is a scar tissue that
it's excessive scar tissue, and there's some papers out that show that the acoustic wave treatment is as effective as Kenalog.
That's awesome,
and that would be huge.
Well, and I know at one of the international symposiums they showed when they do a bypass surgery, they have to harvest the saphenous vein.
Right.
And there's been a beautiful study that showed after they harvest the saphenous vein, they used acoustic shockwave on one patient.
I've used it on some of my cosmetic patients to reduce the increased color in the incision.
In the tissue.
It's been effective.
And I might have to clear up. I know you've been using the device since last year. You've noticed a dramatic decrease in prescribing any.
Yes, we're all in the medical community wanting to reduce the use of opioids in the post-operative, and I've found that I've been able to reduce it by offering the shockwave therapy.
That's awesome.
Yeah.
So, I mean, this could, again, we've said it a couple times on the show, but this could be one of the devices that helps us break out of this opioid crisis. And it's terrible because even today, I mean, some of the people that are in chronic pain management and in interventional pain, their chronic pain that got them in there, they're better. 80% of those people are doing better. But if they get off these opioids, they have these terrible withdrawal symptoms.
Yes. This is, I mean, we're just starting to see the potential for this. I think we're just going to have to get doing it more.
Right. And we've talked about this in the past, but people like you, doctors that are willing to try things that are off-label per se and are working at getting the best outcomes possible for your patients. And that's really what it's about.
But it is. Trying to make people better, whatever it takes.
And go into every link that we can. Finally, you're also, one of the things I'm excited about is you've been working with a local scientist here who's come to put together, I think it's a 6-part, it's a test that will actually figure out if someone's had a concussion. Can you give us a little insight?
Well, we have been looking for a blood marker for concussion for decades. And there's several that have come upon that we've looked at, and sometimes we're always dealing with it being specific enough or being sensitive enough, and so they're putting things together. And this glutamate receptor thing I've been looking at for the past 10 years, and it looks very promising as being it will show ischemic brain lesions.
Mm-hmm.
They will rise, and it will also show stroke or propensity for stroke. It can show even if you've had strokes before. And the other thing is for concussion. What I'm most interested in is the mild concussion, the mild TBI, traumatic brain injury, which doesn't show up on X-ray, but it's the thing that we have to deal with. For when can we let these patients either go back
to normal life, or
go back in
the
game, or in the military, get back on the battlefield? There are a lot of things that we need that we could really use such a marker, and this company has come up with something that actually has a blood test now where you can do a finger stick.
Wow. So we could actually have something on the sideline of a football game and be able to test them to know if they've had a positive. And it's looking at, I think it has 6 markers, correct?
Well, it's glutamate. The one we're looking for the concussion, there are actually 2 there. We're looking for the cortical and subcortical.
So really, up until this point, the only definitive marker for CTEs is when they
Postmortem.
they have to cut through and they look for.
Well, that's the phosphorylated tau protein, and they're coming up with now some things to maybe test that at an earlier time, or maybe image it or something.
Well,
but we need something though, point of care, something
right.
And that's what we're trying to.
It's probably the most underdiagnosed injury, especially in car accidents. We had a wonderful attorney on earlier, and I think so many people, when they're in a jolt in a car accident, don't even know it, what happens to their brain, how it gets thrown around inside your skull. So, well, thank you for working on some of this cutting edge stuff. We're really excited about having you on the team, and you guys can go to our webpage and learn more about Dr. John D. Mullins. Thank you so much.
You're welcome.
All right, folks, we're back. And in this last few minutes, we're really going to talk about one of our overview studies that we did at ATL Pain Institute. And I'll show you our pain news that comes out quarterly. And this is what the extracorporeal shockwave device that we were just talking about with Dr. Mullins looks about. In future episodes, we're going to have the All-Core on, and we're going to bring in Blake Whitney, who is helping spearhead that. And it helps strengthen your core and stability. So we work a lot with neuropathy patients. We see over close to 1,000 new neuropathy patients a year. And this is a study we finished up, an overview study with Dr. Noah Marquez and I, and it looked at 152 type 2 diabetic patients who came through our clinic. And the wild thing was that these patients came in with a pain level of 8. With 0 being no pain, 10 being unbearable pain, take me to the emergency room, they're at a level of 8. And it's like Chinese water torture. This pain never lets up. And these patients, there are spouses, there are parents, and there are grandparents. And it seems like it really affects them towards the end of the day. And 72% of these patients were diabetics. 44% of the patients who come in are on statin drugs or cholesterol-lowering medication for more than 6 months. We're going to do a whole segment on statin drugs and how they have become the most profitable drug in the history of pharmaceuticals. And we'll talk to you about the way other countries deal with cholesterol. And you have to remember, cholesterol and fat is 60% of your brain, 70% of that coating that goes around the myelin sheath. So in this study, and this is even before we had the acoustic wave therapy, we were able to take these patients with low-level light therapy, and over a 5-week period and 12 sessions, we were able to cut their pain by more than half. So it went from an 8 down to a 3.5 and 3.4. And they had a 56% reduction in pain, which was without the use of drugs and surgery. And the cool thing is we're following these people later, and they're still holding this. It's not short term. It's not. So we're working at changing the environment for these small sensory nerves and how they're working. So we also saw a reduction in their peripheral neuropathy questionnaire symptoms, their restless leg symptoms, and an improvement in their balance. 60% of your balance comes from those small sensory nerves, those protective senses in your feet, and that's important. So, in closing, we're going to talk more about the use of this cholesterol-lowering drugs, and you can go to atlpaininstitute.com and download this